Good evening, everyone. On behalf of the Education and Professional Development Committee, I would like to welcome you to today's webinar entitled NYSCHP Compounding Miniseries Part 2. We are thrilled to have Dr. David Braverman presenting Enhancing Safety, Optimizing Media Field Testing and Procedures in Your Facility, and Dr. Emily Polischuk presenting Pediatric Compounding, Challenges and Update. Our first speaker is Dr. David Braverman. He is an assistant professor at Torrey University College of Pharmacy, located in Times Square, New York. Dr. Braverman has worked at the college since 2021. His responsibility at the college includes teaching in the pharmacy calculation courses, along with coordinating the non-sterile and sterile compounding courses, including lab sections. Our second speaker this evening is Dr. Emily Polischuk. She is a clinical assistant professor and the director of practice lab at the University of Buffalo School of Pharmacy and Pharmaceutical Sciences, where she teaches sterile and non-sterile compounding. Dr. Polischuk is a board-certified pediatric pharmacy specialist with a practice site at John Osher Children's Hospital of Buffalo. Before we get started, I'd like to share a quick point. For those who have technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist in resolution. For those who have questions that you would like to direct to the speakers, please use the question box or chat option. The CE code for this program will be provided at the end of the program. Dr. Braverman?
Thank you for the introduction. My name is Dr. David Braverman. We'll be talking about enhancing safety, optimizing media fill testing and procedures in your facilities. I have no financial relationships to disclose in this presentation. And I also want to get out of the way that I'm not doing this presentation from a clean room. It's just the background over here, okay? Some people ask. The objectives for today are to define media fill testing, also to describe the importance of testing to training sterile compounders, also to identify approaches for determining the most difficult and most challenging aseptic procedures, and lastly, to discuss optimizing patient safety through creating a robust and comprehensive media fill procedure. Some abbreviations that I'm going to be using throughout this presentation are provided here, and I may define them in the later slides as well, but here they are for you to view right now. So here's the first assessment question that I'd like for you to answer here. The poll should open any moment. Which of the following statements about media fill testing is not true? Media fill test units should be documented with complete records, including preparation, incubation conditions, and results. The primary purpose of media fill testing is to assess the operator's aseptic technique and secondarily to qualify the compounding environment. Any visible turbidity and microbial growth on a single test unit constitutes a failure and requires retraining and reevaluation of an operator's aseptic technique, or operators are allowed to compound CSPs, compounded sterile products, independently for a short period upon hire before performing a media fill test. Okay, so far looking good. On to the next question here. Another poll question. Which of the following statements about media fill testing is also not true? The conditions should reflect the largest number of personnel and highest complexity of compounding expected during routine operations as determined by the designated person. 3 successful media fills in succession must occur before personnel are allowed to begin compounding compounded sterile products. ACDs automated compounding devices, and other similar equipment designed to assist in compounding of preparation should also be involved in media fill tests if it's routinely part of the compounding process, or third-party trainers and microbiology testing of media samples are acceptable to qualified personnel. All righty, let's see the answers over here. Okay, a little bit mixed results over here. We're going to go through and revisit these questions at the end and see if anybody changes their answers, and maybe we'll all get the correct answer all for both questions. So first, let's talk about what are media fill or aseptic process simulations. Media fills or process simulations are exercises in which the performance of an aseptic activity is evaluated using sterile growth medium. This medium can be directly substituted for the drug or added to it. Simulation of the actual aseptic compounding process using microbial growth medium, typically soybean casein digest medium, also known as tryptic soy broth, instead of the actual drug. So the pictures below that you see, you can actually purchase liquid form media, which you may have seen in labs in college or other places in a petri dish. So that what you see in a petri dish actually can be created by the powder if you're going to create it yourself, if you're going to do a media fill that includes procedures of making non-sterile products into sterile products, or you can buy the liquid form of it as well. And this is going to be substituted instead of the drug for the media fill test. Aseptic process simulations are typically performed before the introduction of newer revised process components, such as products, facilities, equipment, personnel, container closures, and processes, and periodically thereafter. Aseptic process simulations should be fully representative of processing conditions and activities utilized during routine production. Also, USP 797 has verbiage that makes you want to include worst case conditions, such as maximum workloads and duration of compounding. Use the most difficult and challenging compounding procedures and processing conditions encountered in your media fill design. And we're going to be talking about that throughout this presentation. So the purpose overall for media fills or aseptic process simulations is if testing accurately simulates the sterile compounding processes, it demonstrates that the process controls and the operator's aseptic technique compounding skills are adequate to protect the preparation from contamination. That is the whole entire purpose of why anyone does a media fill. Now, what does it mean to do an aseptic process? Well, an aseptic process is a method by which separate sterile components, such as drugs, containers, or closures, are brought together under conditions that maintain their sterility. Components can be either purchased as sterile, or when starting with non-sterile components, can be separately sterilized prior to combining, such as using a sterilizing filter. Where humans are present, microbial contamination is inevitable, and recognize that even under the best conditions, the probability of contamination is never zero. Even terminal sterilization, which is the preferred method of compounding, has a probability of a non-sterile unit of 1 in a million. So it's hardly ever zero. Factors on sterile preparation outcomes is manyfold. First, the environment. The HVAC units Are they working? Are they certified? Are they in proper placement in the rooms and throughout the building? And also, are you compounding in the correct ISO classification? Also, product flow is a factor on sterile preparation outcomes, mainly personnel and facility design. Also, cleaning and maintenance procedures, are they being done? Are you using the correct type of cleaning materials? And are you doing it as frequently as you're supposed to be doing according to USP, or even better than that? Personnel are also, if not the most, the highest on the list of factors that where the outcomes of the sterile preparations are most importantly affected. Are the personnel doing proper hand hygiene? Are they garbing properly and their aseptic technique? And also materials used, whether it's starting with sterile materials or non-sterile materials. So all of these together work hand in hand for the end product, which is why not only does a media fill test the aseptic technique, but also all of these as well are secondarily involved in the outcome of a sterile product. So why is media fill testing important? Well, like I mentioned just before, it qualifies the personnel engaged in sterile compounding because the compounder is the greatest risk to microbial contamination. And it also assures that compounded sterile products can be prepared without contamination. Secondarily, it qualifies the processes and the environment and the operating controls. So a media fill primarily qualifies the aseptic technique of the personnel who compounding, but secondarily may serve as performance qualification in the process validation. Process selection, decision, operating designs, process controls, and monitoring systems are essential to provide the necessary assurance of establishing the capability to maintain sterility. And all of this, when you add them together, is the assurance that there will be safety for the patients for a product that is not contaminated. So personnel training, how often do you have to do these media fills? Well, all compounders, designated persons, and personnel with direct oversight of compounding personnel must complete, as we know, didactic training at least annually on sterile compounding principles and practices. They must also go through gowning and garbing assessment at least every 6 months, including fingertip and thumb sampling. And this has to be done as frequently as every 3 months for facilities that compound Category 3 type products. Training and competency in maintaining the quality of sterile environment should also be assessed, such as cleaning and disinfecting assessment. Usually this is done during media fill testing. And of course, media fill testing, which includes fingertip and surface sampling, at least every 6 months for facilities that compound Category 1 and 2 products, and as frequently as every 3 months for Category 3 products. But for persons who just do direct oversight, this would be annually. So this is a slide in a chart form of the previous slide to make it a little bit easier to view. The ones shaded in a little bit light yellow or beige have to do with media fill, and the one in white is to do with just the didactic competencies. So the garbing competency for the compounder, as we mentioned, which includes glove, finger, and thumb sampling. For Category 1 and Category 2, at least every 6 months, you should do the garbing competencies, and Category 3 every 3 months for a compounder. And the same thing for the media fill and surface sampling. And for a designated person with direct oversight, unless they're compounding, it would be annually. If they were compounding, they would go and use the compounder's schedule. So media fill basics. Personnel prepare a sterile product using tryptic soy broth in a way that mimics their usual compounding procedures. This filled media containers, bags, whatever you compound, are then incubated, typically at these temperatures shown over here for 7 days, and then another 7 days at different temperatures. And if no microbial growth is observed in the compounds that you have prepared during the media fill test, the test is considered passed. Now you can go on to compound sterile products. However, a failed test requires retraining, retesting before the individual is allowed to resume sterile compounding. So let's talk about media fill test design. How are you going to make your test and what will your test look like in your facility? Well, let's talk about the facility and organization type. Are you both the designated person and the compounder? So then, are you going to make your own exam? Or are you going to visualize yourself? Well, you could, but it's probably best to consider external training and someone to view you from third party to do that, just for conflict of interest type of issues. Also, for large companies or hospital systems, do you have the same designated persons for all locations? It's allowed. Is that designated person going to give the same exam for all hospitals? Not all hospitals have the same design and setup in their clean rooms. Also, when designing a media fill test, do you intend to use personnel in between hospitals because of call-outs or shortages? You may want to consider having personnel complete media fill across other sites. Also, when considering making a media fill test, your policies and procedures and your equipment should be similar throughout the systems. If you're going to share personnel without having them do media fill across other sites. Over here, showing a media fill kit, which if you were to do sterile compounding the last decade or maybe even more than that, you're probably used to seeing something like this, a media fill kit, which you can purchase, vials that have TSB in them or other type of media. And they would give you instructions, for example, the bottom left corner, to just take out 5 mLs from set A1 and put it in to set A2 vial and back and forth 4 times, and then you would incubate that vial. Or another exam kit that you may have purchased, you might get 5 vials in the kit, and you were to say, and the instructions would say, take 5 mLs out of each vial and put them into one vial, and then you would incubate the largest vial as an example. Well, these kits may not simulate actual components or processes by facility. So for example, if your facility doesn't compound vials at all, they only compound IV bags. So the component is not a perfect simulation of what you do at your facility. Also, is this how you typically compound? Just take 5 mLs out of each vial and go back and forth 4 times? Probably not. So it is up to your designated person or director of compounding to create an exam for what you may see as a typical day's work in your facility. And why is that important? Because outside auditors, for example, FDA, Board of Pharmacy, etc., may see this and write up that you have not done something that is, for example, worst case scenario, or that doesn't simulate your firm's aseptic production operations. So here's a snippet from a 483 that I found that the FDA wrote up. And I want to highlight that the the write-up included that the firm's aseptic production operations was not under worst case scenario or most challenging and stressful conditions. So they might have used something like a kit that I previously showed, or something that just did not show or simulate a day's average work. Here's another write-up that I found. And by the way, these write-ups about aseptic simulations not being a challenge or not being similar to a day's work is one of the most frequent write-ups that you can see in sterile compounding for sure. So that's why we're here to talk about how to make an exam, a media fill exam, that you won't get a write-up like this in the future if you are visited by an auditor. So USP 797 uses the verbiage of most difficult and most challenging. That's how you should create your media fill exam. So the simulation must capture elements that could potentially affect the sterility of a compounded sterile product, including, but not limited to. So on the left-hand side are elements you may want to consider adding to your exam. And on the right is the reason why you want to add these to your exam and the things they are intended to challenge. So for example, in your exam, you want to add the longest time of a certain manipulation. Also, you may want to consider adding a compound that has the most manipulations, or the most complex type of preparation, or the largest batch size. And by adding those elements to your exam, you're challenging aseptic technique because of operator fatigue, and also the quality of the equipment used. Does it hold up over a long duration of time, like a filter, for example? Also, other elements you may want to add in your exam is the number of personnel in the clean room or segregated compounding area. There's increased risk of contamination when there's more people in a room than less. So if you were to do a media fill by yourself, you're likely to pass that than if 6 or 7 or 8 people were in that room, which might be a typical day's work. You also want to add some interruptions in there and level of garbing. We're going to talk about interruptions later in this slide deck. Also, do you want to do media fill in horizontal and vertical if you are compounding in both types of hoods? And you might want to add technology and automation if that's a typical day's work as well. And this challenges, again, aseptic technique, an increased risk of contamination, and also quality of equipment used. Now, we're talking about worst case conditions and most challenging conditions, but it's very important that a media fill should not be used to validate bad working practices or events or conditions that may pose microbial contamination. So what you're not wanting to do is, well, USB 797 says I should do things under worst conditions. So I'm going to intentionally turn the temperature high in the room. I'm intentionally going to increase the relative humidity in the room, and I'm also going to ruin the pressure that's happening in the room between the rooms. That's not what it's intended to mean by worst case conditions, although those may happen on on a certain day where the pressure is not working or the temperature is not correct, but you're not going to purposefully do that for the exam. So you're going to still conduct this exam under conditions of a normal day, that is proper in temperature, in humidity, and in pressure, and also under dynamic conditions. I underline that here because that's probably something that's found in write-ups as frequently as when media fills are not done challenging or under normal daily operations. And what dynamic conditions mean is under normal compounding operations when personnel are present and actively involved in the process. So what that means is if a normal day has 6 compounders in the clean room, your media fill should also have 6 compounders during the exam, not by yourself. As mentioned before, if you're by yourself, it doesn't reflect an actual day's work, and that would not be considered dynamic conditions. So locations of compounding, where are you going to create this exam, right? Let's say your facility has a couple of different category types, a couple of different hood types. Well, the designated person or the director of compounding is going to decide which one is realistic, both realistic and the most complex or challenging to compound in. So, does your facility compound in a segregated compounding area, a category 2, which is a regular compounding room, or both? If both, which one did you determine is more difficult to compound in or possibly more contamination type? And which one has the most average amount of personnel in the space in one time? And which one has more opportunities for contamination, such as sinks, open space, doors that may not be automatically opening versus rooms that have automatic opening doors? Wherever the compounder performs the media fill that you deem both most challenging and representative of a typical day, justify the location in the media fill document. So for example, in your media fill document, you may write somewhere, after assessing rooms X, Y, and Z, it has been determined that room Y has more compounders in a room at any given time and does not have touchless entry. Or you can possibly write, the segregated compounding area has the greatest microbial risk as compared to a category 2, and thus that's why we made the exam in that type of area. Also, you may want to determine which one's a little bit more difficult to compound in if you are, in fact, compounding in both types of hoods, vertical versus horizontal. Now, USP 797 does not tell you to do it in both types of hoods. However, I have seen in my lifetime, especially in category 3 or 503B style write-ups, that they sort of suggest or sort of prefer, although not explicitly required, if you were compounding, a single person were compounding in both types of hoods to prove that they are maintaining sterility and aseptic technique properly in both types of hoods. But since you are doing only one exam, you were to determine which one is more difficult, challenging, or which one do I compound the most in, etc. It's up to you to decide when you're creating this exam. Automation. Are you using any of these items throughout the day? A Baxter repeater pump, an automatic vial filler, maybe a TPN machine. All of these would have media running through them instead of drug when you're doing your exam, if you are incorporating them into your exam. If you only do TPNs, well, then it's fairly obvious that you'll do a media fill in only the TPN machine, etc. When considering garbing and gowning for your exam, media fill participants should wear the most complex attire. So for example, if compounders in a hazardous drug clean room wear goggles and in the non-hazardous drug compounders, they don't, well, that's an extra thing to touch and put on your body. You may want to consider adding goggles to your exam to put that on for a compounder. Compounders should wear the facility outline garb. And again, don't intentionally wear personal clothing like street clothing or say, well, it's most challenging if I don't wear gloves, right? I'm introducing the most contamination if I wear non-sterile gloves or no gloves at all. And then document on your media fill document, well, that's the worst case scenario. I'm in street clothes, I'm not wearing gloves. That's the worst case scenario. Well, it's not a realistic worst case scenario because I don't think you would walk into a compounding room if that was the case, if there were no gloves available, etc. Hand hygiene should follow standard operating procedures. And if compounders have different garb in different areas, such as SCAs or category 2, justify why this garb in this media fill exam is challenging, which means, again, challenging means the most likely to cause contamination and also still representative of a typical day, and write that in the media fill document. Compounding procedure. What is your most challenging manipulation that can happen in a shift? Ampules, are they more complex in your view than a 2 ml vial? Is that more complex or difficult than a 10 ml vial? Some would argue, yeah, in that order it is. What is the largest amount of products that you may prepare at one sitting, or the longest amount of time in one sitting for a single preparation? So is 200 units your most challenging when you're sitting at one time? Or is 2 hours the longest you can be in one time? So you rate yourself, you certify yourself to these numbers. And perhaps consider a combination of all types of preparations in one media fill test. So perhaps you're in a facility that can do everything in a day's work. So maybe your media fill exam will include 40 syringes, 20 bags, 2 eye drops, and also maybe one bag created via TPN or repeater pump. And that would be your exam. So what could you add as potential challenges or things that may cause contamination in a procedure? Well, these things over here are not all inclusive, but some things that are common occurrences that provide extra rigor in the exam. And by extra rigor means most likely to possibly increase contamination. So a glove change, that happens all the time. A soiled glove, a ripped glove. So maybe in the exam, you should include a glove change to simulate a tear. Compounders get up to retrieve more supplies in the middle of a preparation. That would simulate missing items that are needed. Leaving the compounding room and coming back in, that could increase contamination. And that's a normal occurrence. How about compounder doffs the garb halfway through the preparation and regarbs to simulate a restroom or lunch break? Compounders stop what they're currently preparing and introduces something else, safely of course, into the hood to simulate a stat emergency preparation that has to be done right now. Or dropping materials on the floor or producing a minor spill. Common occurrences that could introduce some extra rigor into the exam. And then these things will justify realistic worst case scenarios and their quantities as it pertains to regular preparation. So once you create your exam and you produce your exam, of course, you have to document everything. And because if you don't document, it never happened. So there are a couple of things that you are going to have to document. The first thing is visual observation, the person who's watching you do this media fill. Criteria is usually dependent on the facility's SOPs, and visual observation can be done in real time. So a designated person, a third party, a director of pharmacy could be right behind you as you're doing this exam, watching you in your aseptic technique and making sure that you're following the exam. Or retrospectively, I've seen some people wear like these sterile GoPros, and then the designated person can watch back. It is allowed. I don't think it's the best way, but it could be done. And of course, you'll document, was the garbing and gowning correct or not acceptable? The cleaning and disinfecting procedure, did they do it properly using the proper items? Was that acceptable? And aseptic manipulations, was that acceptable according to standard operating procedures? And of course, also document the results of the actual procedures, such as the media fill products, the glove and fingertip sampling, and of course, the surface sampling of the actual hood. And a failure in the media fill, glove, fingertip, and thumb sampling, even one unit constitutes a failure. So under the MediaFill products, even 1 unit is a failure. Glove, fingertip, and thumb sampling, anything greater than 3 CFU from both hands is a failure. And a sample from the surface, direct compounding area, anything larger than 3 is a failure during a MediaFill test. And those numbers are from USP. If you wanted to make it more stringent, you could, I suppose. But these numbers are straight from USP 797. And of course, you're going to document the visual components, the name of the person that was evaluated and the evaluator, the date and time of the exam, the test type, was it gowning, turbidity that you viewed, CFUs that you viewed, inspection of components for cracks, leaks, aseptic technique, evaluator comments and or corrections, and then of course results. Did the person pass or fail? And to document the actual procedure, you're going to again have the name of the person that was evaluated and the evaluator, date and time, the simulation process, the actual process, and the justifications, especially if you're going to add those lines of rigor, the components that you're using, including manufacturer lots and expiration dates, detailed description of the sampling, incubation temperatures and duration. If done in-house, you can also send your samples out to a third-party lab to incubate and give you a certificate of incubation. And then, of course, comments or corrections, and then results pass or fail. So what may your document look like? Well, I put something together right here. It's not entirely, the next 3 slides are not entirely what your MediaFill document may look like, because it probably is going to be way longer than this. But things you may want to add to your document for MediaFill exam. So you're going to, of course, have the name of the operator, date and time, right over there. And MediaFill testing will be done. For example, in this case, I wrote Pharma Labs, which is, let's say, a third party lab that will do the incubation. Of course, you're going to attach that to this document, which will eventually end up in a file for the employee. Things that you may add, for example, in the document, the duration. You can add something such as filling time not to exceed 4 hours. And of course, you'll have a justification for that. Maybe your shift is mandating that everybody has to take a 15-minute break every 4 hours, and that's why you cannot compound for longer than 4 hours at a time, or whatever reason you have. Acceptance criteria, of course, it's 0 contaminated units. And in this case, you're using a Baxter repeater pump and creating 250 units of 2 ml vials, and then an additional 10 vials for growth promotion. So this is a document that's doing non-sterile to sterile. Then, of course, you may add in the middle some language about why you're doing a certain amount of milliliters. So, for example, you would think 250 units of 2 mLs, you're only going to create 500 mLs of volume. But there's a justification in the middle as to why you're going to create more mLs, because you're going to do 0.1 for overfill. So that's going to add an additional 25 mLs, and then more mLs for filtering, et cetera, et cetera. Then on the bottom, you may want to add to your document, as mentioned before, all the components that you're using. And especially if they're sterile, there are lots and expiration dates. Something you may want to go back to in the event there was a failure, and you can possibly go back and see that, well, you actually use an expired item, and that would help you out in your root cause analysis over here. So all your equipment and devices will be written down as well. Then, of course, the actual procedure, I only have 4 in this one, but of course, the procedure is probably going to be way longer than that. And then just wanted to bring your attention to the arrow which says rationale for worst case scenario. So This exam has 250 units because no operator is to compound more than 250 units in one time. Also, there in this procedure, an operator must interrupt a compounding session at least 3 times to retrieve more vials from the pass-through, possibly creating turbulent airflow or introducing an item that was not properly staged or wiped or cleaned. So that's something that's real case scenario that could be added to the exam, and it has the justification. And then the justification for a 2 ml vial is because a 2 ml vial is more difficult to stopper and seal than a larger vial because of its 13 millimeter neck versus a 20 millimeter neck in the 5, 10, and larger vials in that. And then, of course, you're going to have the monitoring portion on the bottom, and the TSA and SDA lot numbers you may want to add for the surface sampling that you're doing. Then any other notes that you want to put in there as well could also be added to the document. Of course, this is just going to be 3 slides of what a document may look like, but more often these media fill exams are 20 pages long, to be honest, sometimes that I've seen, especially if you're adding third-party certifications to them, that you're going to staple them to this, etc. Of course, you want to write if the person passed or failed, and sign that, and then write a revalidation due date, which could be anything between 3 or 6 months, depending on how what you're compounding and how if you want to do better than USP suggestion every month, for example, then you would put the date that the person has to do this exam one more time. And then, of course, you may want to add the signature of the person who created the exam, viewed the exam, validated the exam with the person who was actually assessed. This is something that you also may add to your media fill exam, a checklist if the person passed or failed, start to finish, hand hygiene, all the way down to the incubation. Did you do it? Did you not do it? This basically includes all the visual and all the procedural things that you would have to document in the media fill document. So you can create yourself a checklist as well, just like this. And in summary, really, media fill is just 4 steps. It's the setup, which is garbing, cleaning, and preparation in the clean room. The actual simulation, which is the substitution of media instead of drug. The incubation period, which is a total of 14 days. And then the evaluation, which is the documentation and the evaluation of the things that were compounded. And if there is no growth or turbidity, then the test is passed. So in conclusion, media fill testing is a simulation used to qualify processes and personnel engaged in sterile compounding to ensure that the processes and personnel are able to prepare compounded sterile products without contamination. Performing personnel aseptic media fill testing and process verification are critical metrics in any sterile compounding quality system to ensure patient safety. The number of manipulations of each unit and the number of units in each sequence should reflect the most complex and prolonged aseptic manipulations likely to be encountered during a normal workload production. Detailed documentation is key as regulatory bodies such as Medicaid and Medicare services, state boards of pharmacy, departments of health, FDA, and other accreditation organizations enforce USP standards or include them in their standards. And remember, if it's not documented, it didn't happen. So that's why these media fill documents tend to be pages and pages and pages long, especially if you're writing every single thing that you are doing. With all the items that we mentioned today, it's a long document for sure. And that's a good thing, actually. And in case of failure, retraining should consist of reviewing the appropriate SOPs, learning tools, direct mentorship, as well as direct observation of all processes. And remember that qualified personnel and processes equals patient safety assurance. And that's what we're striving to do with all of this. So now that we did all of that, let's see if the answers improve or change at all in the assessment question number 1. So which of the following statements about media fill testing is not true? Media fill testing units should be documented with complete records, including preparation, incubation conditions, and results. The primary purpose of media fill testing is to assist the operator's aseptic technique and secondarily the compounding process and environment. Any visible turbidity or microbial growth on a single unit constitutes a failure and requires retraining and reevaluation of an operator's aseptic technique. Or lastly, operators are allowed to compound sterile products independently for a short period of time upon hire before performing a media fill test. Okay, this one most people got correct in the first try, and it improved for sure. So operators are not allowed to compound sterile products independently until they pass a media fill. I am licensed in 11 states personally, and there was, I don't know if it is now, but I remember there was a state, I don't want to misquote here, but I think it was Texas, that if a pharmacist failed a media fill test, they gave them 1 week of like a buffer to still compound. It was sort of like a well, the patients need something, need their medicine, so we're not going to, and there's no other compounders. So they let you do it for 1 week, but that's a Texas thing, so not New York thing. All right, on to the next question here. Which is assessment question number 2. Which of the following again is not true? Not true. The conditions of a media fill should reflect the largest number of personnel and highest complexity of compounders expected during routine operations as determined by the designated person. 3 successful media fills in succession must occur before personnel are allowed to begin compounding. Automation and other similar equipment that are designed to assist in the compounding preparation should be involved in the media fill test if it is routinely part of the compounding process. Or third-party trainers and microbiology testing of media samples are acceptable to qualified personnel. This one, the first time was a little bit mixed. Let's see if tip the scale here in a certain direction. Here we go. Okay, so we got the right answer for the majority, which is B. You don't have to do media fill 3 times. Actually, the glove and garbing is something that has to be done 3 times. 1 media fill is good enough to allow personnel to begin compounding. Okay. That is my presentation, and I am open for questions at all.
At this moment, I do not see any questions in the chat, but while we are waiting for the questions, let me ask you a question. First of all, thank you very much for excellent presentation. My question is, how can technology such as automated compounding devices, video monitoring can actually enhance both the testing procedures and staff accountability?
Yeah, sure. So if you were to add automation, such as Baxter repeater pump, if you're using that solely as your compounding method, or in addition to your compounding method, I remember in the hospital when I was a compounder, sometimes I would just use my hands to do certain bags, and then I would get up and maybe get an order for a TPN and use the Baxter repeater pump. If you're using any type of automation, such as a Baxter repeater pump or a TPN machine or an automatic vial filler or anything really, you should incorporate that into your media fill testing to prove that, because you're going to be touching the buttons. And so the touching of the buttons is increasing contamination. You're going to be switching the lines and hooking things, which is also opportunity for contamination. So these are things and reasons why to add them to your procedure if that's something that you would routinely do. Because if you are if you are using those items, but you're only putting, let's say, 5 IV bags into your exam, what's the assurance that when you're using an automated compounding device that you are actually maintaining sterility? So that's the purpose of adding those into your media fill exam.
Thank you very much. I don't see any questions at this moment, so we will go into the next speaker's presentation. And if any questions for Dr. Braverman come in, we will make sure that those get answered and distributed to attendees.
Thank you.
All right, everyone. I'm Dr. Emily Polischuk, and I am here to talk about pediatric compounding tonight. I'm a clinical assistant professor at University of Buffalo School of Pharmacy, and I coordinate both our non-sterile and our sterile compounding courses. But my background in clinical pharmacy and dispensing pharmacy is really in pediatrics, so I'm excited to talk tonight. I get to talk specifically more about pediatric compounding than I do when I teach our students. So by the end of this webinar today, you should be able to describe the rationale for compounding medications for pediatric patients. You'll be able to identify patient safety issues that exist in pediatric compounding. You'll be able to list benefits of using standard concentrations when compounding for pediatric patients. And you'll be able to access and apply literature and regulatory guidelines to ensure safe pediatric compounding. So we'll start with just a brief review of the rationale for pediatric compounding, why we are so often needing to compound medications for pediatric patients. I think this is pretty intuitive, something that most of you probably already know or could come up with some ideas about, but I just want to review it and highlight a few things that have changed over the past few years. So when we think about compounding for pediatric patients, we probably most often think about, well, these are kids, so we're going to be compounding liquids because they can't swallow pills, and there's not a lot of commercially available liquids available. That's kind of our first, I think, thought of compounding for pediatric patients. And that's still one of the more common reasons that we are compounding, despite some of these efforts I'm going to talk about here over the past 20 years or so to improve pediatric drug development and formulation development. We still do have a lot of medications that we use in children that don't have the appropriate formulation that a small patient might need. So we know the Best Pharmaceuticals for Children Act, or BPCA, was introduced just over 20 years ago in 2002. And this is an incentive program. So it incentivizes pharmaceutical companies to voluntarily conduct pediatric studies. And what this kind of gives them as a reward for doing this is a 6-month extension of marketing exclusivity for their product. So studying their medication in children kind of gives them this little bonus. So it really should encourage manufacturers and drug companies to want to study their drugs and come up with formulations for pediatric patients. And then we have the Pediatric Research Equity Act, or PREA. This was introduced the following year in 2003. And this is a law that gives the FDA the authority to require pediatric studies when a drug is expected to be used in a substantial number of children. So prior to this, drug companies could introduce medications that they knew would be used often in children, maybe even primarily in children, but there really was nothing to ensure that these pediatric studies were being conducted. So now the FDA kind of has that backing and that authority to require these pediatric studies be done, which again is going to encourage these pediatric formulations to be created in that drug development stage. And these laws are working. As of just a few weeks ago, close to 700 medications have been assessed or studied under either one of these two laws or both of them. So they've definitely made a positive impact in the development and labeling of drugs for pediatric patients. But again, we still have a lot of drugs that we're routinely using in children that don't have a commercially available liquid formulation for our children who can't swallow pills, or maybe an appropriate IV infusion concentration for our pediatric patients. So that need for compounding for pediatric patients really has not gone away all that much. Again, just to really review why we're compounding for pediatric patients, again, some of this is intuitive. Like I talked about a little bit already, most often we're really kind of lacking that age appropriate formulation. So we've got maybe a younger child that can't or won't swallow pills. So we're going to compound a liquid formulation or maybe powder papers that could be mixed into their food or drink. That's going to kind of depend on the medication and the patient and the clinical situation. But we're modifying that because there's not an age-appropriate formulation. This could extend to topical formulations as well. Maybe we have a topical steroid that's needed for a pediatric patient, but even the lowest concentration available is more potent than what we need. So we might compound kind of a diluted ointment for that patient so that it is appropriate for their age. We might be compounding because we need a very specific dose for a patient. So maybe we have a child or adolescent then that can swallow pills and there's pills available, but based on their precise mg per kg dosing for a medication, we still need to compound, a liquid to give them a very precise exact dose. We see this certainly with some of our cardiac patients or patients on blood pressure medications. So when they're on that precise mg per kg dose, they might not be able to take the tablet or the capsule size that's commercially available. And rounding is just too significant of a dose change. It could really have clinical implications there. So maybe compounding that liquid, or again, perhaps a powder paper, or maybe even a compounded capsule could kind of fit the bill for a patient like that. We might not compound for palatability issues alone. That really wouldn't be appropriate, but it's something we kind of need to consider and think about, when we're thinking about what kind of medications we're going to give our children. Certainly those of us who are parents know how hard it is to administer a bad tasting medications, especially if it's something a child is expected to be on chronically. So it's something we need to think about when we are prescribing medications or recommending medications or compounding them as well. At the hospital, we actually do medication taste tests for our pediatric medical residents, and we let them taste just a little bit of some of the more commonly compounded or reconstituted liquid medications, just to give them an understanding of what they're prescribing, what it really tastes like, what they're asking their patients to take, what they're asking their parents or caregivers to administer to these children. Not that it's necessarily going to change their prescribing patterns, but maybe just to give them a little bit of an appreciation of when we should think about, gosh, this clindamycin oral solution just tastes terrible, and I have, a 6 or 7-year-old, maybe we could work with that patient to try to get them to swallow pills if that's an acceptable dose, or maybe a flavoring agent is needed, and that prescriber could work with the pharmacy to make sure the compound or the reconstituted solution or suspension is flavored appropriately. So palatability isn't going to be the reason we compound something necessarily, but is a consideration in there when we're thinking about what kids are going to be willing to take. Allergies or intolerance to excipients, we're going to go into kind of the age-related excipient issues a bit later, but just the presence of certain excipients in commercially available medications, that might lead us to compound an alternative. Most commonly, I'm thinking about like red dye allergies with medications where a dye-free preparation is not available. We might need to compound something for that patient. And then lastly, I have dietary considerations here. We see quite a bit of this in our pediatric population that are on a ketogenic diet to help manage a seizure disorder. This can be really challenging. This is often our more refractory patients with seizure disorders that are placed on this diet. And this diet is going to restrict all sugar and carbohydrates. So now we've got to find all these medications that might be available in oral suspensions and solutions, but they contain sugar. So we've got to replace these with carbohydrate and sugar-free options. So at Children's Hospital in Buffalo, we're almost always going to have, a carbohydrate-free Keppra compounded. We've done carb-free phenobarb compounds of trileptal. There are also meds, though, that don't have carb-free formulas. So then sometimes we're thinking about, maybe lamotrigine or zonisamide powder papers, or when we can manipulate those capsules and tablets in solid dosage form. So those dietary considerations also can play a big part of why we might be compounding for pediatric patients. As I touched on, even though we have, BPCA and PREA, a lot of kids still need meds that just aren't commercially available because either the dose isn't right for them, the concentration is inappropriate, which comes into play a lot in sterile compounding. We're going to talk about this later. Or maybe there even is that right formulation. So there's a liquid available or, an IV formulation available, but it contains an excipient that we're just hesitant to use in young children. And like I said, we'll talk about excipients later when we talk about some of these patient safety issues. There can be a lot of different reasons why pediatric patients might need a compounded drug. Of course, this could range from kids who just need, a one-off compounded medication for a very short duration, and ranges up to our medically complex children that we're very familiar with in the hospital that have a variety of chronic complex conditions. And these patients can be on 10 to 20 medications per day, where many, if not all of them, might be compounded depending on the age of the patient and if they are taking oral medications, if they are taking medications via a G tube. So we do have a lot of children with those chronic conditions that we compound for quite a bit. Children with rare diseases on medications or sometimes also dietary supplements, they might only be available in solid dosage forms targeted again for adult patient populations. So we've got to manipulate those. And those rare disease patients often are sometimes on IV, chronic IV infusions. So those patients are going to be having a lot of sterile compounding needs as well. Pediatric oncology, again, a huge compounding need, not just the chemo products themselves, but these patients are often on more complex compounded IV fluid regimens. These aren't just stock bags that are available. We have to really tailor these for these patients. Those patients might be on TPN. They have additional supportive care meds, antiemetics, things like that we might be preparing, and as well as oral chemo that might need to be manipulated, but has to be done with all those appropriate considerations from USP 800. So a lot of considerations for the oncology population. And then lastly, I have our NICU babies here. And I spent the first couple of years of my career in pediatrics working in a NICU. And so this is definitely a place I liked to spend some time and definitely had a lot of compounding considerations. Our neonates might be our most specialized pediatric population. They're obviously our smallest, and that's going to cause us to run into a lot of issues when we're thinking about compounding. As neonatology has evolved over the years, we're caring for more and more very low birth weight and extremely low birth weight neonates. So even working in a NICU with standard concentrations where we're used to small patients, you might get that baby born at 23 weeks that weighs 350 grams. And now you're needing even lower compounded concentrations for all your IV meds. And you might be compounding TPNs with ingredients that are volumes that are really too small for even your automated compounder to add. So there's a lot of kind of problem solving in that NICU compounding area. Probably why I liked working in this population so much as a clinical pharmacist, because you really get to kind of take into those account those clinical considerations on top of the dispensing and compounding issues that you run into. So I say all this just to kind of emphasize that while pediatric compounding can be just making a suspension for a child who can't swallow pills, there are these niche populations within pediatrics that really require a lot of attention to detail and extra problem solving. That said, while our need for pediatric compounding is huge, we don't always want to just jump to compounding a med for kids. That can be really easy for us to do in a hospital. We are staffed usually to compound easily. We have resources, we have ingredients, we have the supplies that we need to compound. So it could be easy to think, oh, well, I'll just compound exactly what this patient needs while they're here with me. But we know that might be a different story when that patient goes home. Maybe their access to a compounding pharmacy might be different. So I was definitely kind of guilty of this early in my career, but through a lot more time and training, I realized that with the situations our patients face with medication access, and how our revised USP chapter, specifically 795, may have made that even more challenging, which we'll talk about later. We really don't always want to just jump to compounding for every single patient. So we want to think about those clinical situations. Instead of compounding a liquid, is there a way I can alter a tablet? Can I crush it and sprinkle it on, some pudding or applesauce for this patient? Is that something a parent might be more comfortable with in compounding something, or if that compounded liquid is hard for the patient to access? If I'm thinking about sterile compounding, when should I be dispensing just a vial of a drug to a floor or from, a Pyxis or automated dispensing cabinet? and expecting a nurse to drop that dose? Or when should I be dispensing a patient-specific dose in a syringe that I've prepared in the pharmacy that I know is exactly the right dose to administer to a patient? And similarly, if I know a drug must be diluted before it's administered, which is the case for many pediatric patients, should we be doing that ourselves in the pharmacy, in the clean room, or are we putting that on nursing? And if it's a dilution that we're going to be doing a lot of, should we be doing it in the pharmacy, or should we consider maybe outsourcing that compound to another facility? Even at Oshai in Buffalo here with our resources, there are still some simple dilutions and compounded sterile preparations that we just make so much of that we do outsource them because of the time, how intensive they are to prepare. I'm thinking a lot about like the one-time doses of some of the narcotics our neonates get in the NICU. Every single one of those doses needs to be diluted because 50 mic per ml fentanyl is just far too concentrated for patients that size. So instead of asking our nurses to dilute every single dose that they might give to a patient, or for us to be constantly doing that in pharmacy, that's something we've chosen to outsource. So most of you are probably at institutions that have policies in place to kind of address these scenarios that I'm describing, but we know there's outliers, particularly if you're maybe at an adult institution and you're not routinely caring for pediatric patients. So in addition to those policies that you have in place, it's also kind of important to have procedures and things to do when you have to approach these decisions. So there's kind of some consistency in how you handle these compounding considerations, from shift to shift, from day to day. So everyone knows kind of how these things should be handled. Next, I want to talk about some of the patient safety issues that are specific to compounding for pediatric patients, and some of the things that have maybe changed in recent years or been updated recently. We know there's many safety issues when compounding meds for patients of any age, and we know a lot of the things that we do to make sure our compounding is safe. But there's a few things specific when we're compounding for our pediatric and neonatal patients that I want to cover here. There's lots of safety concerns that we could talk about getting into pediatric compounding. Today, I just want to hit on a few of these. So I want to talk about the stability issues and how we need to consider how that might impact our patients' access to compounded medications, especially, again, those patients who are chronically on a high number of compounded medications. We need to think about the impact of contamination risks on pediatric or even more so neonatal patients that don't have fully developed and fully functional immune systems that our older patients have, and how those contamination risks could really be more impactful and more significant for our smaller patients. I'll get into the limitations of the dispensing and compounding technologies that we'll use. I'm also going to talk about the issues with excipient toxicities in neonates and some older children as well. And then I'm going to spend a good bit of time talking about the variability that exists in compounding formulations, and the variability and concentrations of what we compound and those safety implications there. So starting off with our recently revised chapters, 795 and 797. 2 weeks ago in this webinar series, we had a really great review of USP 795, non-sterile compounding revision. So I'm not going to get deep into these, but I want to talk about some of the updates that might just be a little bit more impactful to those of us compounding for pediatric patients. To be clear, there's no pediatric specific recommendations in these chapters, but just again, a few of these changes that were made, I think hit those of us who compound for pediatric patients maybe a little bit harder. So starting with 795, our non-sterile compounding updates, overall, what we came away with was just more stringent requirements for just about every step of the non-sterile compounding process. More stringent requirements for personnel training and competencies, the facility design and compounding areas. We have more cleaning and sanitizing we have to do, more equipment we might need, more documentation. So overall, it's just kind of a heavier lift to do non-sterile compounding than it used to be. I remember as an intern 20 years ago, compounding in a large grocery store community chain, and we would be doing, making ointments right next to where we took our breaks, and probably not really doing best practices. And I think 795 has kind of, these updates have emphasized how important it is to have these, really stringent requirements for all these things to keep our patients safe. But my hypothesis here is that this is really going to lead to fewer pharmacies that are engaged in non-sterile compounding, which could make it harder for outpatients to access compounded medications. There's no data to really support this. Again, this is a hypothesis, but something I have just kind of seen and heard people talk about. When 795, the revisions were kind of posted in 2022. I had community pharmacists kind of reaching out and saying, well, wait, are we not allowed to compound anymore? Because some of the larger chains did say, we can't meet these requirements. We're not going to compound anymore. So some of those more easily accessible, again, ointments or oral solutions that patients kind of could go a lot of different places for, I think it's getting a little bit harder. So we have to think about that for when we're discharging patients on, or maybe considering what kind of medications we're going to place them on in the hospital. Is this a medication that somebody can easily compound them, based on their geographic location and their access to medications? Another change in 795 was this update for the non-aqueous oral liquid dosage form beyond use date. Used to be 180 days. It has been further limited to 90 days now. Not a huge impact in pediatrics. We do a lot of liquid dosage forms for our patients, but not too many of them are these like non-aqueous, more oil-based dosage formulations. So that was shortened, but not so impactful for us. Then I think what we do have to think about a lot, though, is what, again, was covered 2 weeks ago in this webinar series, which is these aqueous compounded non-sterile preparations. And USP is saying that if we are going to use dating for these oral preps that are beyond use dating from USP of 14 or 35 days, depending on the presence of a preservative, we need to have antimicrobial testing to prove that they are that those extended dates are appropriate. So basically what this means is some of that extended dating you may have been using for oral solutions or suspensions or really any of your compounds, these aqueous compounds, because you had the stability information, it may not be appropriate anymore based on the lack of antimicrobial testing. And that's study specific. That means really going to the primary literature and seeing if that data exists there. I know some of our even tertiary references are still updating their resources to kind of comply with some of this. So again, just because you have that stability saying you can extend to, 2 months, 3 months, whatever it is past that USP beyond use dating, you might not have that antimicrobial information and then you really can't use it. So we should all kind of be reevaluating our oral suspension and oral solution dating and formulations and see where that's at. Sounds like a really great project for maybe like an intern working with you, kind of going step by step through those and seeing if any of your beyond use dating needs to be updated now. Moving on to our sterile compounding updates from Chapter 797. Two kind of things here that I think that are impacting our pediatric patients a little bit more maybe than our adult patients. So first we have kind of a positive change. The in-use limit for single-dose vials was extended from 6 to 12 hours. And that's important for pediatrics because we are often taking, something that was manufactured in a size that is appropriate for adults and just using a tiny little bit of that. So those of us working in pediatrics, and maybe this is happening in adults as well, but I would imagine less so, you might take a small amount of a medication from a single dose vial, then we would maybe keep it in the hood for a couple hours and we have to throw it out at 6 hours. So now we have 12 hours to keep those single dose vials to once they are in use. So that's extended that a little bit for us. Where we have kind of missed out a little bit is this new in-use limit for our stock solutions. So we now have this 12-hour in-use limit for our compounded sterile preparations. This in-use limit for stock solutions wasn't really addressed in the 2008 version, but what we know now in the most recent revised chapter of 797 is that when compounded sterile preparations are used as a component to compound additional CSPs, that's defined as a stock solution, and we do this a lot in pediatric patients. We know that they must be entered or punctured in ISO class 5 air, so within our hoods and our clean rooms. They must be stored in the condition that beyond use date is based on, so either refrigerated or room temperature. So things that we were doing beforehand, but here's the really big change for us is that maybe these stock solutions can be used for sterile compounding for up to 12 hours after the first dose is drawn, or the assigned beyond use date, whichever is shorter. And usually that's going to be 12 hours. So some of these stock solutions, may have had the stability to give a beyond use date of 24 hours, 48 hours, maybe up to 4 days or beyond based on how it was prepared and the stability data that we had. Now we know that they only have a 12-hour in use state once they are first punctured. So at a pediatric hospital where the majority of the medications you're going to dispense for IVs are pediatrics or are patient specific, you're drawing up that exact volume. You can't just keep that bag in the fridge for days at a time. So now we got to think about minimizing waste. We might need to think about making smaller stock solutions. So you're not going to make a 500 ml bag of an antibiotic that can last you, the 4 days for the old beyond use state you thought you could use. You've only got 12 hours once you puncture it. So let's make, a couple 100 ml bags so that we're not having so much waste. Another thought is less frequent batching. So as opposed to doing several batching runs throughout the day at a hospital, you might do that less frequently. So just enter that bag during one, couple hour run, make all your doses for the entire day. We also know this ends up on kind of the back end having more waste. So you might make a bunch of doses. If you're only making doses for your pediatric patients once a day, you might drop a bunch of syringes and then that patient's discharged. So then you have that waste there because those are just going to end up in the garbage. So definitely a big impact to those of us using a lot of these stock solutions and knowing that you can only keep them for 12 hours after that first dose is drawn out of them. Moving on to some of the limits of technology and automation here. I just want to emphasize, of course, I'm not saying that technology or automation is bad. We know we should incorporate these compounding and technologies and dispensing technologies into our workflow whenever we can. ISMP really emphasizes that these are designed for safety and do add a lot of safeguards to our compounding practices. However, we do need to know where are the issues with pediatric patients or pediatric compounding. What of these technologies, maybe where can they not adapt and what do we need to do to make them work for us? So a couple different situations here. TPN compounding is one for sure. If you're working at a pediatric institution, you're certainly compounding a lot of TPNs. If you're using an automated compounder, there are limits on those automated TPN compounders to the volume of the additives you can add. I know specifically I have the most experience with Baxter's pump, and the limit there is 0.2 ml. So you might need for a neonatal or even pediatric patient an electrolyte dose or a dose of an additive or a trace element that is less than 0.2 ml. So your pump can't add that. That needs to be manually added. And what's the process going to look like in your clean room for that? Who's going to draw that dose up? Who's going to check it or watch it be administered? So that's a process you kind of have to adapt to. This is definitely most problematic for NICU patients. For some of our smaller patients or for patients with small volumes in their TPNs, they might have 4, 5, 6 additives to that TPN. So that can definitely increase our chance for errors, for mixing up dilution or mixing up our volumes and just adding those things manually to that TPN. So again, needing to have safe processes for that. And sometimes if that's happening a lot, maybe you're noticing that there is a certain electrolyte on your TPN or trace element perhaps that you are constantly having to make it be an additive for your patients because it's just they're never getting the right volume of it. You might think about maybe creating a dilution, a standard dilution to put on your pump. And we've done that before in pediatrics when we have the stability data for certain electrolytes. So as opposed to using that commercially available concentration of the electrolyte, will create something that's more dilute to hang on our compounder so that it is still our compounder that's adding it as opposed to having a technician or pharmacist need to add that volume. We've also done things like customize our trace element formulation. So again, we know the dose we're giving, we're always going to be adding a volume that's can be measured by our compounder and not having those manual additions because that volume is just too small. Thinking about our workflow management system, so things like Dosage, where we are having our EMR kind of in our computerized system kind of talking back and forth with our workflow management system in the IV room. One of the main issues I've seen kind of come up with this is sometimes there's dose calculation issues where our workflow management system may not be able to calculate a volume past a certain decimal, but our mg per kg dosing for a small or very specific dose patient may have too many decimals in it, basically. So we've got to kind of go into those orders from our providers and do some manual rounding to make sure that our when it gets into the clean room and a technician or pharmacist is going to prepare it, Dosage knows the appropriate volume to tell that compounder to do. So Again, important if you are having these issues or if you are thinking about implementing a workflow management system in your IV room for compounding. It's great, can't recommend it enough, but you just got to think about what happens when you are maybe adding a volume that is not rounded quite appropriately, or there's some kind of manual workaround that needs to be undertaken. How's that going to be done at your pharmacy? And then lastly, infusion pumps. Of course, we're going to use infusion pumps, and these are so important for our patients to make sure that these medications are being delivered at the appropriate dose by using guardrails for pediatric and neonatal dosing, and making sure those infusion rates are appropriate. But of course, we can only have a certain number of these, and we need to make sure that the standard concentrations that we're using, that we have enough of them available at our institution to provide medication flow rates that are deliverable on our infusion pumps. Again, are not too many decimals, are not less than the smallest flow rate, ml per hour. Sometimes that's 0.1, sometimes it's higher depending on your pump and depending what it is dispensing from. So just kind of taking all of that into consideration when you are building those libraries or kind of reviewing those libraries from time to time, thinking about compounding for pediatric and neonatal patients. I wanted to talk about the kind of issues and challenges that surround excipient toxicities for a pediatric patient. One of the main challenges here is that there really is no complete list of drugs containing potentially toxic excipients. So there's no list we can go to say these are the drugs that might have these excipients in or do have these excipients in them. So pediatric pharmacists, or really any pharmacist that may be dispensing or compounding for children, have to be aware of this issue, that our medications contain excipients and they are not all safe for children. Because formulations change over time, we're probably never going to have a list of like, this is the med that has this excipient. And that's just should be a medication in your head that you're always thinking about. But we still do need to be diligent to identify and evaluate the presence of these excipients when we're compounding for pediatric patients. So we do still have that responsibility. So what's the best way to do that? We also need to then again consider things that the clinical significance of that excipient specific to our patient. So how much of the excipient are they going to receive in that compounded medication or commercially available preparation? How old is the patient? Do they have some kind of organ dysfunction that might lead to more accumulation of the excipient, which could lead to a higher potential for harm? All of those things. So a lot for us to think about as pharmacists. And again, when we don't have that list of just telling us that every preparation of drug A is always going to have this excipient, we don't use it in kids, that's a lot for us to think about. However, this is usually a kind of a common set of drugs, and the more you work with them and the more you work with children, the more you kind of learn about that. A drug like IV lorazepam is a great example. We know the injectable formulation of lorazepam contains propylene glycol. Propylene glycol is an excipient that can cause issues in children like lactic acidosis, hypoglycemia, can cause seizures when it's administered in very high doses to children. However, this is an excipient where we have some specific guidelines and dosing cutoffs. So if we have a patient that does need to get IV lorazepam, there are calculations we can do to check if this amount that they'll receive will be safe the way that we're going to, compound that infusion for them or those intermittent doses. This is also true for another excipient, benzyl alcohol. This is present in a lot of IV formulations of different medications as a preservative, but it is known to cause gasping syndrome in neonates. So, but it's also dose related. So we have a well-established cutoff for safe dosing. So we know the best practice is always to use preservative-free formulations when we compound for neonates, but we actually can kind of complete these calculations to make sure that if they did receive these preservatives, would it be in a safe amount based again on the concentration of the preservative in the medication at the dose the patient's going to receive over a certain amount of time. It's not something I'd advise or suggest you do. Certainly the best practice is always to give the preservative free containing medication when it exists. But there have been times, even when I've practiced over the years, when maybe a preservative-free formulation of a drug is on shortage, and we've start to have to make these considerations. What patients, based on their weight, would be appropriate to, or where would it be safer to give them a little preservative, and where do we need to really restrict that preservative-free formulation for? So where do you go for all this information, especially if you're not routinely working in pediatrics? Again, not a solid list of all the medications that contain these potentially harmful excipients, but what we do have is some great info in the kids list. So the kids list, if you're not familiar, is the list of key potentially inappropriate drugs in pediatrics. This is a list that's compiled and published by a panel of 12 pediatric pharmacists from the Pediatric Pharmacy Association, and it's published in the Journal of Pediatric Pharmacology and Therapeutics. And it's just what it sounds like. It's a list of drugs and drug classes that would be inappropriate to prescribe for all pediatric patients or maybe a select subgroup of pediatric patients. So for those of you practicing in adults, this is a lot like the Beers list. Those drugs we don't really recommend, or maybe we think about using in patients older than 65. This is our pediatric version of it. And what's nice is, in addition to drugs, this publication also includes excipients. So while we don't have that list of meds, we do have in this publication a nice list of those excipients that we are specifically concerned with in pediatric patients. I have a list of them here on the slides. This is going to be some of our preservative agents like benzyl alcohol, sodium benzoate, benzoic acid, some alcohol preparations like ethanol or alpha alcohol, isopropyl alcohol, certainly our parabens, methyl and propylparabens, phenylalanine, polysorbate 80, and propylene glycol, as I mentioned before. So these are our most concerning excipients when we use them in children. So the kids list contains obviously this list, what potential issues arise if you do use these or administer these to pediatric patients, and then some management strategies or recommendations, like some of those kind of dosing cutoffs like I talked about before. The kids list was first published in 2020, an updated version that was published literally last week. So last Monday, the August edition of JPPT was published with an updated version of the kids list. So really hot off the presses here, really current. I have that citation at the bottom of the slide. The article is available to the public. So if you're dispensing or compounding for peds at all, this is just a great link to grab and save for future reference when you're maybe working with a new formulation and you want to think about it. You're checking it for excipients, whether you're sterile compounding or maybe you have a new oral solution you're working with or oral suspension you're thinking about administering to pediatric patients, and you want to kind of go through this list and those considerations. Great thing to have on hand here. The last major safety issue I want to spend kind of the most time on is the variability in concentrations when compounding. This is a potential safety issue for compounded meds for any patient, right? Not just for kids. But we know our pediatric patients are most often being prescribed oral liquid medications. And this is probably the formulation where this mix up with the concentration can most commonly occur. Although it could occur with compounded IV meds as well, as we'll talk about. This is probably the most significant area where I've seen these issues with compounding in peds over the years, kind of the biggest safety issues and where I've seen errors be made. And this confusion surrounding what concentration a patient should be on has definitely led to meta errors. And where this is most often happening is certainly during transitions of care. So patients being admitted to the hospital, discharged from the hospital, whether that's to home or some other kind of lower level of care. This is when these are happening, even when a child's being transferred from one hospital to the next. Issues where we are not paying close attention to the concentration of what they are compounded, whether it be a liquid or an IV medication. That's where we're going to definitely see some meta errors. Medications compounded for pediatric patients have multiple compounding formulations at different concentrations. We know this. I think sometimes we don't know how many different concentrations really are available. This is actually an exercise I have my students do, where the week that we learn about oral suspensions, I say, well, here's ursodiol. Why don't you go out and find a appropriate compounding formula and make a master formulation record using it. And that brings them to usually Lexicomp, and we see, oh, well, there's a 60 milligram per ml oral suspension, but wait, there's also a 20 milligram per ml oral suspension in the same monograph, and a 25 and a 50. So, we might think of there being one or two for a medication, but to know there's this much variability for a pretty commonly compounded oral suspension, it's significant. And I'd like to go over it with my students, because it's just so important for me to kind of impress upon that even if they never compound, this is something they should be thinking about when they're thinking about compounding medications. So how do we avoid that? How do we kind of minimize this risk that happens with different compounding concentrations? Using standard concentrations is kind of going to be the answer to that, and that's what we'll focus on in this next section. I thought I would start with just a few examples from my own practice over the years. I always try and share these kinds of examples with students as well. Or if I'm educating new pharmacists, maybe training new pharmacists in pediatrics or new pharmacy residents in practice. I don't want to be scary, but I think by understanding where things can go wrong, that's how we prevent those things from happening. And again, we can talk about the big things we should be doing as institutions, but even just in our own practice and how we are handling our patient care day to day. By knowing where the issues can happen, this is how we prevent them from happening in the future. So my first example here is an infant that is discharged on sildenafil for the treatment of pulmonary arterial hypertension, not uncommon at a pediatric institution. While the infant was inpatient, the hospital was compounding the oral suspension, commonly compounded oral suspension, and the concentration, it's only available at one concentration, compounded 2.5 milligram per ml, or I should say, we really only have data for this single concentration when we're compounding. However, at discharge, the patient goes to pick up the medication from the outpatient pharmacy, and the pharmacy dispensed a newly available, commercially available oral suspension. So previously was not available and everybody was compounding it. Then a new suspension became commercially available. The hospital was not using it yet. The outpatient pharmacy was, and the concentration of that commercially available suspension was 10 milligram per ml. The prescription was written only with a dose in mLs, not milligrams. So the patient did receive a fourfold overdose of the medication by receiving that more concentrated, commercially available oral suspension at home. In my second example here, this is more of a kind of transition between hospitals issue. So we had a child in an outside ICU that was receiving clonidine oral suspension for the treatment of iatrogenic withdrawal. There's no commercially available formulation for clonidine, so the hospital was compounding an oral suspension. That concentration they were compounding that at was 0.1 milligram per ml. The patient is transferred to a different hospital for escalation of care, is continued on that clonidine, but that hospital compounds at 0.01 milligram per ml. So not only a different concentration, but a variability, like by a factor of 10, so that number looks very similar. That change in concentration was not noted during the transfer, and the patient received a tenfold underdose because they were just administered the same volume, and they did experience withdrawal symptoms. And then my last example here is really an example of what could happen less with compounding, but just with different preparation techniques being used inpatient versus outpatient. So an oncology patient was discharged on a 10 milligram dose of enoxaparin subQ daily. While they were inpatient, the pharmacy was preparing patient-specific doses, but as an outpatient, they were dispensed, a 30 milligram 0.3 ml syringe, really the smallest commercially available denomination of the medication, and the caregiver administered the full syringe. That education piece was missed there, as well as maybe the communication between the inpatient and the outpatient side of what's the best way for a provider to be administering kind of a partial dose of a syringe like this in the outpatient setting. So not so much a compounding error, but an issue with where we are compounding and making patient-specific doses inpatient, and then they are going to be dispensed a commercially available product outpatient. So again, not to talk about kind of those scary errors that can happen, but when we hear these things, we think, oh, next time I see this dispensed, let me think about what I can do to avoid those issues. In addition to kind of our own practices, of course, there are these national efforts to standardize medication concentration. So I'll talk about the ASHP Standardized for Safety initiative. If compounding for neonates, the Vermont-Oxford network paired with ISMP has released some standard concentrations. And then within kind of those national efforts and initiatives, we need to have our own institution-specific policies and protocols. So ASHP Standardized for Safety, this is a national interprofessional effort to standardize medication concentrations to reduce errors, especially during transitions of care. So really targeted at kind of some of those errors that I was just talking about. And ASHP has published these standard concentrations for compounded oral liquid medications, for IV continuous infusions. They have separate recommendations for adult and pediatric patients, as well as PCAs and epidurals. What ASHP says for compounded oral liquids is that one standard concentration for each medication should be used. In their own list of these standard concentrations, there's only one exception. Amiodarone does have two separate concentration recommendations based on patient size. Other than that, each medication included in this list just has one standard concentration. ASHP, of course, recommends always using the commercial product whenever available, limiting your own dispensing practices at your institution to one concentration as much as possible. We know this can be hard, especially whether you're an adult institution that occasionally dispenses for pediatrics, or at a children's hospital, we dispense, again, for our tiniest neonates all the way up to full size, 18, 19, 20-year-old patients. So to try to find one concentration of an oral liquid that would be suitable for all those patients, that can be really challenging. Of course, ASHP reminds us we should always have primary literature support and stability studies for any compound we're going to be making. And I kind of added our caveat here, like we talked about earlier. We also want to have antimicrobial studies if we're extending that beyond use dating past what USP 795 has. They recommend considering taste and palatability, like we talked about, and also thinking out to those reimbursement considerations. So again, touching on that medication access after discharge. If we're going to compound an oral liquid inpatient, easy, not a big deal. Is it going to be something that can be considered at home, or should we be starting to think about during admission, how is this patient going to go home? Are they going to be able to afford this compound? Are they going to be able to access this compound? Is there a different way or a different medication altogether we need to consider because of that? Still in standardized for safety, moving on to those pediatric continuous infusions. Again, there's separate adult and pediatric recommendations for concentrations. Of course, we know we are going to need multiple standard concentrations here for each included medication. It would be great if there was one, epinephrine concentration that would suit all of our patients, or one morphine concentration. That would be great. It's just not possible when we're dispensing such wide dosing ranges, such different size patients. So we know we've got to have more than one. They recommend using, of course, commercially available products when possible. Really, in pediatrics, this is very hard. The continuous infusion concentrations that are available for patients are almost never appropriate for our smaller patients, especially if they're on lower doses of continuous infusions. They recommend limiting to one concentration when possible, and that may be possible for some medications, but more often, especially if you are at a hospital that's, again, caring from neonates all the way to adult-sized patients, it's going to be almost impossible to do. They recommend considering fluid status when selecting concentration to dispense, of course, more concentrated for patients where we need to be restricting fluids. And then also recommend kind of thinking about operational considerations and waste as you select what standard concentrations you're going to have at your institution. So that's ASHP standardized for safety. When we think about neonatal drug concentrations, we have recommendations, again, from the Vermont-Oxford Network in conjunction with ISMP, and this is to standardize neonatal drug concentration. So ASHP does adults and pediatric, and these groups have taken on neonatal recommendations, and they are stratified. So there are different standard concentration recommendations for patients weighing greater than or equal to 500 grams, and then different concentrations that are, of course, lower for our patients less than 500 grams. So we know having these standard concentrations reduces the risk of medication errors for our neonatal patients, also allows that standardization of the drug libraries that we're going to use for our NICU patients, and just kind of reduces the risk of errors when we're compounding for these patients, because we're kind of used to compounding these standard concentrations. So in addition to these kind of national guidelines, we then have to take that information and develop these institutional standard operating procedures. And most of you, I'm sure, have institution-specific standard concentrations for your IV and probably your oral liquid medications as well. I'm sure you have a process by which these are selected and approved, and maybe going through P&T, other committees that make sure that these are appropriate and safe. But what I would encourage you to think more about, and where I've kind of run into problems in practice over the years, is what procedures do we have for when the standards don't work? Because while we try to anticipate and plan for just about everything, we know sometimes those standard concentrations, whether it's an IV or an oral medication, they might not fit a certain patient population. And I don't have a recommendation for what to do every single time, but what I can say is it's really important to have a process in place for what you do when these things happen. So what do you do when your lowest standard concentration of an IV medication can't be run on an IV pump? that volume is too low. It's going to be 0.07 mLs an hour, and that's not what your infusion pump can run at. So you probably do need to come up with a non-standard concentration. Who approves that? Who comes up with that? How does that get onto the pump? What if it's off hours? What if it's a weekend? Reverse of that, what if your most concentrated standard concentration of an IV medication is causing fluid overload for a patient? And you've probably got to think about maybe researching something even more concentrated if it's available or if there's published data. But what's the process for that? Who's doing that? Who's approving it? Who's communicating with nursing and getting that added to the pump library? Going into our non-sterile compounding, what if your compounded oral liquid concentration is either too small to be measured for a certain patient? So you've got that tiny neonate, and while you thought you kind of considered every situation, it's too small to be measured in your smallest oral syringe. Or flip side of that, is it too large to be tolerated? Maybe you're compounding clonidine for your, NICU for NICU babies or tiny cardiac babies. But now you have, an 18-year-old who needs an oral liquid dose of it, and it's too many mLs for them to tolerate. What are you going to do then? So I don't have a solution for these problems necessarily. I think the solution is to have a procedure in place. So especially those evenings, those off hours when these problems come up, how is leadership dealing with these, and how are these problems kind of worked through at your institution? So despite all the standardization we have, these national recommendations, policies at your own institution, we know there are still inconsistencies that can occur. Not everyone is going to compound their oral liquid medications or their IV medications at the exact same concentration. Where is this going to happen? Again, transitions of care. Patients are discharged from the hospital, they're transferred to another institution, or also when patients are admitted to the hospital. This is when these errors, are going to happen. So what can we do? What are safe practices that we as pharmacists should be employing to make sure that these confusions and variability in concentrations don't lead to med errors? I have this picture of a road here because I think of this as a two-way street. Think of the responsibilities that we have as hospital pharmacists and the responsibilities that community pharmacists have as well to make sure that all of this is as clear as possible. So if we are hospital pharmacists, things that we could be doing to make sure this doesn't happen is to make sure that we are always conducting thorough medication reconciliation. So verifying dosage units, making sure we know the dose of a liquid a patient was receiving outpatient in milligrams, micrograms, MEQ, whatever it might be, not relying on transcribing from mLs, teaspoons, tablespoons. This might mean going into the room and asking for the bottles that the patient has if they brought in their medications with them, finding where they get their prescriptions filled and calling the pharmacies. These are things we really commonly do at the hospital to make sure that we are administering the appropriate dose of these medications when they're compounded. We also want to, on the flip side of that, make sure we're really doing thorough discharge counseling or medication teaches when our patients are going home. What I really like to do if I'm doing discharge teaches is actually have in my case, the caregivers, the parents usually picking up the medication bottles and bringing them to me when I do the discharge teach, showing them how to draw them up, verifying that the concentrations being dispensed on that, are on that bottle and are the same as we did inpatient. So going through those steps as much as you can in your practice to make sure that as you're sending those patients out, they know what to do and they have the right medications. And then our other job is to really assist prescribers when they're writing medications or prescriptions or orders for compounded medications. So making sure that those doses and directions are really clearly stated. So when those scripts go to the community and the outpatient pharmacies, those pharmacists know what to do with them and they have very clear information. And they're not left to make assumptions about what we're doing on the inpatient side, especially in those, these months we're kind of in right now, July, August, September. We've got new residents in our hospitals. Maybe they're not familiar with our prescribing systems. And if they're especially adult residents and maybe kind of doing that one-off pediatric compound prescription, it's really our job to make sure they're comfortable and prescribing that appropriately. In the community, when interpreting prescriptions for compounded medications, again, same thing. We want our community pharmacists to always verify dosage units. If they do get that prescription from the hospital and it only has mLs on it, making sure they're communicating with us about that. We don't want community pharmacists to make any assumptions about what is concentrated in an institution when compounding. It would be nice if we all use the standard concentrations and we could assume that. That's just not always the case for whatever reason, or maybe there's multiple concentrations being used at a hospital. So whenever I educate community pharmacists or can kind of have that conversation with students who will be community pharmacists, I like to make that really clear with them. And then lastly, making sure our community pharmacists are labeling compounded medications really clearly with the appropriate concentration. As I said, sometimes I will be looking at bottles of medications from the outpatient side to interpret that for a medication reconciliation and what a prescriber should prescribe in the inpatient side. And it's surprising. Sometimes those concentrations are not on there. So I have a name of a medication, I have a volume, and, I'm just not comfortable assuming that this must be the standard concentration from ASHP or whatever it might be. So I'm going to call the pharmacy to verify that. So anytime our community pharmacists can be really clear in their labeling of their medications, that's helpful to us on the inpatient side as well. Another thing we can do is just have a really heightened awareness of where, again, these issues can happen. And where I've seen that in the past is when new liquid formulations become available on the market that were previously compounded. So that's like that sildenafil example I gave earlier. We were compounding sildenafil for years and years and using it more frequently in neonatal or pediatric cardiac patients when this new formulation came out, and there was not a universal acceptance of that commercially available preparation. So we had to be really clear to prescribers, to outpatient pharmacies, where that confusion could happen. So if you're kind of aware of, oh, here's a new oral suspension, it's commercially available, that's great, I don't have to compound anymore. But if it's a different concentration, what kind of, what do I need to look out for? What do I need to educate prescribers on? And even more importantly, probably patients and caregivers that, the volume that they're drawing up for a patient or for their child may have changed, but it's the same medication. Another thing too is drug shortages. Obviously, we've had such a huge number of drug shortages over the past, 10, 15 years that I've been in practice now. And sometimes those do necessitate compounding that we're not doing otherwise, but that could be a regional issue or a health system issue. So we might be compounding something in the hospital where our patients are going to go home and they might go to a CVS or a Walgreens where they can still get that oral suspension, or they've still got some on the shelves. And if there's a different concentration there, that's going to be an issue. So again, not a very specific recommendation here, but just a recommendation to be aware of where these problems can occur. Lastly, I'll just touch on pediatric compounding resources. There's really no secrets here. Our pediatric compounding resources aren't necessarily different than those adult compounding resources you're used to using. I tell my students tertiary references are a great place to start. So hopefully you have access to something like Lexi Drugs, Micromedics, Clinical Pharmacology. They've really kind of amped up their extemporaneous preparation sections in these monographs over the years and give you a good place to start with that information. There are websites that are helpful. I have some of them included here. If you're not kind of consistently compounding in pediatrics, these could be helpful to you. Nationwide Children's Hospital in Columbus, they have a great website of all of the compounding formulas that they compound for their inpatients. So again, it might not be what is being done at any other children's hospital, but these are evidence-based compounding formulations if that's really what you're looking for. UNC, their School of Pharmacy, has a great website called Pharm Labs that has a lot of compounding educational material. It's really excellent if that's kind of the venue that you're in. And they also have formulation records there. So really extending outside of those oral suspensions, they have a lot of different kinds of formulations, eye drops and eardrops and topical preparations. So if you're out there looking for something, they may have it as well. And then other than that, again, you're really using the same kind of places that you're looking for monographs and compounding information as all other adult types of compounding. Key point when you're looking at these references, especially again, these tertiary drug references, these websites, just a caution to, when you're thinking about extending the beyond use dating past USP 795 recommendations, most of these references still contain formulations that only have stability data and not the antimicrobial data that is stipulated by the revised chapter. So they may have longer beyond use dates than you really can give it with this new 795 dating. So just something to kind of be aware of and maybe going back and looking through. I think the best compounding resource, if you're going to get into pediatric compounding and you're not a pediatric pharmacist, is to just phone a friend, find a resourceful compounding pharmacy that compounds pediatric medications a lot. Maybe your local children's hospital or some other inpatient institution that's doing a lot of pediatric and neonatal compounding, and really rely on them for that compounding information. Especially I worked at Children's Hospital of Pittsburgh prior to this, and we had a really great relationship with a lot of our outpatient pharmacies and a very specific procedure for when outpatient pharmacies wanted to come to us for compounding formulations and information. And, this was the old days, so we were faxing everything, but sending them that information in a very easy way for them to get it because we knew they just might not have the resources that we did at the hospital, and also helped with that continuity, of course, of what we were doing inpatient and continuing outpatient. This collaboration, it's needed for safe and successful patient care. None of us is going to be the expert in every single element of this, but really relying on pediatric pharmacists when you need them, that's going to be key if you can kind of build those relationships. So to summarize, pediatric compounding is essential. We don't have those age-appropriate commercial formulations still for our children across the board. We have patients with individualized dosing needs. We have excipient concerns with commercially available formulations. All of this is always going to kind of necessitate compounding for this patient population. The patient safety risks that we want to kind of be aware of is the variability in concentrations, especially at transitions of care, excipient toxicities, both in our commercially available preparations, but possibly in compounding medications as well. All of this really, we need to be vigilant for our pediatric patients, and we need to have as much standardization as possible. These standardization efforts like Standardized for Safety and Vermont Oxford Network, ISMP's neonatal initiatives, these are really aimed at reducing medication errors and improving consistency. And we should really rely on these as we develop our own institutional policies and protocols. And then lastly, those safe transitions of care, I just can't say it enough, require really thorough medication reconciliation during admission, clear labeling of medications in the community, and excellent caregiver education. So we are making sure we are preventing these dosing errors, and this continuity of care across all these different settings can be ensured. I have my references here. And again, I have that link to the kids list if that's helpful for anyone, and I'm happy to take any questions.
Thank you very much for a very informative presentation. I do not see any questions at this moment, but while we are waiting, please allow me to ask. So as you mentioned, there are various incentives for manufacturers to manufacture pediatric preparation, but how can we as pharmacists advocate for broader research and development of pediatric-friendly commercial formulations to reduce the reliance on compounding?
Yeah, so I think those of us working in industry and really having a strong pediatric presence in industry in these drug manufacturers is going to be really important. I really do think the PRIA specifically, but BPCA as well. These did the majority of the work for us, saying that these drug companies can't kind of get away with just marketing and testing drugs that they intend to market for children, not on children. But it has to go beyond that too, and having those additional clinical considerations. I mentioned, sildenafil as a medication that because of, I believe because of PRIA, came out with this oral suspension formulation. However, that formulation does contain sodium benzoate, which is one of those excipients that I said, could be concerning in certain populations. I'm not saying don't use it across the board, but it was something when that came out that we had to really evaluate and say, is this going to be, well, we have a commercially available suspension for kids, great, it can give them the doses they need. We did still have, a theoretically unsafe excipient for certain patients in it, and had to take into account those clinical considerations. So really, pediatric pharmacists having that presence, and all pharmacists and pharmacists that are having presence in industry, having that voice for our youngest patients is really important.
Thank you very much. I don't see any questions, but if anybody has any questions, please feel free to email us. So thank you again, Drs. Braverman and Polischuk, for providing tonight's webinar.